Hello, welcome to MNE 60703, Philosophy of Science and Evidence-Based Nursing. My name is Natasha Binti Anas, and this is my presentation entitled Nursing Models of Care in Clinical Practice, Jane Watson's Theory of Human Caring. So let's take a look at the overview of Jane Watson's Theory of Human Caring. Jane Watson developed the theory of human caring between 1975 and 1979 during her tenure in University of Colorado. She wanted to convey nursing as an emerging discipline and a distinct health profession with distinguished values, knowledge, and practices, as well as ethics and missions to the society. She viewed caring as the ethical and moral ideal of nursing, with interpersonal and humanistic qualities. Caring is a complex concept that embraces elements of holism, empathy, communication, clinical competence, technical proficiency, as well as interpersonal skills. The theory of human caring views caring as the essential core of nursing to enhance therapeutic healing processes and relationships. This helps to surpass rigid objectivity of nursing that only focuses primarily on procedures, tasks, treatments, and technology. So, in a sense, caring brings emotions and spirituality into nursing practice. So, Watson's philosophy of human caring is closely related with Nightingale's philosophy of nursing. Nightingale herself championed nursing as a spiritual practice that incorporates both caring and healing to be in harmony with nature and the environment. This results in nursing's moral and ethical art of attending to basic human needs with beauty and grace. So let's look into the clinical caritas process. Clinical caritas process is an updated version of the curative factors which Jane Watson developed in 1979 that serves as a foundation and framework for the science and practice of nursing. She expanded the curative factors to clinical caritas process, which combines spirituality, love, and caring in the new paradigm. So let's look into the clinical caritas process. Number 1, practice of loving kindness and equanimity within the context of caring consciousness. Number 2, being authentically present and enabling and sustaining the deep belief system and a subjective life world of self and the one being cared for. Cultivation of one's own spiritual practices and transpersonal self-going beyond ego self and being sensitive to self and others. Developing and sustaining a helping, trusting, authentic, caring relationship between the nurse and client. Being present to and supportive of the expression of positive and negative feelings as a connection within deeper spirit of self and the one being cared for. Creative use of self and all ways of knowing as part of the caring process and engagement in artistry of caring healing process. Number 7, engaging in genuine teaching learning experience that attends to unity of being and a meaning and attempts to stay within others' frame of reference. Creating healing environment at all levels, physical as well as non-physical, whereby wholeness, beauty, comfort, dignity, and peace are potentiated. Number 9, assisting with basic needs with an intentional caring consciousness, administering human care essentials which potentiate alignment of mind, body, spirit, wholeness, and unity of being in all aspects of care, attending to both embodied spirit and involving emergence. And finally, opening and attending to spiritual, mysterious, and existential dimensions of one's own life, death, soul care for self and the one being cared for. So in all sense, these clinical caritas process will be the framework of how we care for our patients. Now we move on into our case study. Mr. X, a 49-year-old Muslim man diagnosed with ascending colon cancer, was admitted to the surgical ward on the 1st November 2018 for right hemicolectomy the next day. The client appeared slightly anxious and mentally distracted during room orientation, but responds appropriately to questions. In terms of chief complaint, he mentioned of having moderate abdominal pains after meals, bloating, and frequent passing of loose stools since 20th October 2018. His skin is dry, slightly pale, and non-edematous. He had independent full range of motion, normal lung and heart sounds, but had a distended abdomen with palpable mass at the right lumbar region. For his past medical history, he has hypertension on amlodipine 10 mg OD. He claimed to have no surgical history nor drug or food allergies. In terms of elimination, the client stated that he would normally pass soft stools each day and pass urine for 5 times per day. He is married with 2 children, both of which are still in primary school. He worked as a customs officer while his wife is unemployed. The vital signs are as follows: blood pressure 140/89, pulse rate 79 beats per minute, respiratory rate 18 breaths per minute, saturation 98% under room air, and with a pain score of 3/10. Bowel preparation and preoperative fasting began in the evening after admission. So during the preparation itself, the patient verbalized his concern about his safety during and after surgery, along with the well-being of his family should his condition deteriorate. So on the 2nd November 2018, the immediate post-surgery phase. We received the client from the operation theater. He was drowsy but responded to call. He had a laparotomy wound dressing, a right abdominal drain, urinary catheter, on patient control analgesia, IV fluids, and compression stockings. His estimated blood loss during surgery was 300 mL, which was only managed through fluid replacement. The resected tumor was sent to the lab for histopathological examination. So during the immediate post-surgery phase, the client constantly verbalizes pain at the incision site and was also experiencing post-op nausea and vomiting. The vital signs are as follows: blood pressure 139/85, pulse rate 105 beats per minute, respiratory rate 22 breaths per minute, body temperature 35.6 degrees Celsius, saturation 96% under room air. His blood glucose was 4.2 millimole per liter, and his pain score was 7/10, a sharp incisional pain nature. So on the 3rd November 2018, the client became restless, pale, and tachypnic in the morning. He was hypotensive, and his oxygen saturation was 93%, so he was given 2 liters of oxygen via nasal cannula. His urine output is low at 18 mL per hour, and there was also evidence of active bleeding as the total abdominal drainage was 1,000 mL of sanguineous fluid with presence of parectal bleeding. Hemoglobin is at 9.0 grams per deciliter. So we have given him colloids, 2 units of PEG cells, and 1 unit of platelets, which were administered without any reactions during the procedure. He underwent colonoscopy for an endoscopic repair of perforation as there was an anastomotic leak. After that, his condition began to improve. He was calmer, having pinkish skin tone, and breathing at regular rate. So his blood pressure improved to 130/85, and his oxygen saturation is at 97%. His post-transfusion hemoglobin was at 12 grams per deciliter. So from the 4th of November until 16 November, which was the day he was discharged, the first few days of the post-operation, the client had difficulty to perform his self-care needs due to his post-operative fatigue. We assisted the client with his routine until he was more stable to perform them by himself. His urinary catheter was removed on the 4th of November, and the client was able to empty his urinary bladder easily. Pain tolerance to surgical wound improved, thus the PCA morphine was discontinued, and they resumed with oral analgesics. His diet progressed from clear fluids to normal diet and was tolerating orally. Additionally, he was able to achieve soft stools and regain normal bowel habits. The abdominal drain was removed on the 10th November once the drainage was subsided. However, upon receiving the histopathological results from the surgeon on the 12th November, the client and his wife became devastated after being told that the cancer had reached metastatic phase. Both client and wife were in disbelief and very tearful upon hearing the results. Despite that, the client agreed for consultation with the oncologist for adjuvant chemotherapy. He was promptly discharged on the 16th November with no complications. Now let's look into the nursing care plans. So the first nursing diagnosis, anxiety related to surgery and hospitalization, as evidenced by client verbalized concerns about his safety during surgery and family financial constraints that may result from prolonged hospitalization. The client will achieve reduced levels of anxiety before procedure and throughout the hospitalization. So first, we have to assess the levels of anxiety as a baseline reference. Number 2, engage in therapeutic communication to allow the client to express his feelings, concerns, and fears. Exploration of client's feelings can help to calm his mind and emotion during the ordeal. Number 3, facilitate the client to instill motivation and hope within himself. Number 4, provide clear instructions with rationale to the client regarding procedures and medication so that he can get an insight on the importance of the procedure and medication, which will help earn his cooperation. Number 5, allow family and friends visits to provide the client with psychological support through the words of comfort and encouragement. Number 6, encourage prayer and supplication as a form of spiritual protection against negative thoughts. Number 7, document changes of anxiety and interventions provided to monitor his progression. So the evaluation, the client had achieved low levels of anxiety as evidenced by the client appeared more calm and verbalized that he is more optimistic about the surgery. So the next nursing diagnosis, which is acute pain related to surgical incision as evidenced by presence of fresh incision wound on client's abdomen and his verbalization of pain with a score of 7/10 with blood pressure of 139/85. So the client will verbalize reduced pain at incision site and achieve lower pain scores at post-operative period of 3 hours. The interventions are assess client's level and nature of pain to obtain a baseline data. Number 2, optimize client position to prevent application of pressure on surgical site. Number 3, limit number of visitors to create a quiet and calm environment to prevent psychological distress. Number 4, keep patient on bed rest throughout the day to avoid stress on the abdominal muscle. Number 5, ensure abdominal drain tube is functioning properly to avoid accumulation of fluid within the abdominal cavity, which can worsen the surgical pain. Number 6, ensure the PCA tubing is not kinked and client's IV cannula is patterned. So this is to allow for effective delivery of morphine to control client's pain. Number 7, educate the client on the use of PCA handheld button so he will be able to perform self-delivery of morphine when he needs it. Number 8, provide reassurance to client that nursing team will closely monitor his condition. Number 9, report to surgeon if the client's pain cannot be controlled despite of interventions provided. And number 10, document client's level and nature of pain, morphine dosage, along with other nursing interventions to monitor client's progress. So in the end, the client verbalized reduced sensation of pain with pain score of 3/10 at post-operative period of 3 hours. So next is impaired comfort related to surgery as evidenced by the client complaint of pain at incision site with pain score 7/10, body temperature at 35.6 degrees Celsius, shivering and experiencing post-op nausea and vomiting. So first, as usual, we have to assess the client's level of comfort to establish a baseline data. Number 2, ensure the client's room is warm by increasing the air condition temperature and reduce the fan speed. Number 3, provide a warming blanket for the client. Number 4, promptly attend to client's needs so he would feel more secure, thus reducing psychological distress. Number 5, limit the number of visitors for the first post-op day to reduce unnecessary interactions with the client. Number 6, offer the client vomit bag when he feels he wants to vomit to avoid spillage and stain. Number 7, ensure the client is receiving adequate amounts of morphine or analgesics. Number 8, administer antiemetics to inhibit neurotransmitter actions in the brain, which are responsible for nausea and vomiting. And number 9, document nursing interventions and any changes in client's level of comfort to monitor his progress. So the client had achieved higher levels of comfort as evidenced by the client feels that he is more comfortable, pain score at 3/10, body temperature at 36.4 degrees Celsius, and no experience of PONV. So next is decreased cardiac output related to decreased ventricular filling, secondary to blood loss. So first we have to closely monitor client's mental status, blood pressure, pulse rate, breathing rate and depth, oxygen saturation, skin condition, urine output. Number 2, keep the client rest in bed to limit activity as it can allow for temporary circulatory compensation. Number 3, ensure client's environment is warm by increasing the air condition temperature and cover the client with the warming blanket. Number 4, provide reassurance and comforting presence to curb anxiety and empower the patient. Number 5, withhold antihypertensives. Number 6, ensure presence of IV access for administration of fluid and medications. Number 7, administer 2 liters of oxygen via nasal prong. Number 8, administer antifibrinolytics. Number 9, administer colloids, packed cells, platelets as ordered. And number 10, document care and client's condition as a reference to monitor progression. So in the end, after 6 hours of nursing interventions, the client had achieved adequate cardiac output as evidenced by him being more calm and alert, having pinkish skin tone, blood pressure at 130/85, pulse rate at 89, respiratory rate at 20 breaths per minute, oxygen saturation 97% under room air, abdominal drainage has reduced to 90 ml of serosanguinous fluid, and there is absence of rectal bleeding, along with hemoglobin of 12 grams per deciliter. Self-care deficit related to post-operative fatigue as evidenced by client unable to independently carry out proper hygiene, prepare his own drink, self-dressing and self-toileting task. So first, assess client's ability to perform specific types of self-care as a reference to plan out the appropriate interventions needed. Number 2, plan activities to prevent fatigue. Number 3, ensure the environment is safe for the client to perform the activities. Number 4, assist the client during toileting, bathing, and dressing. Number 5, encourage family members to participate in the activities of self-care. Number 6, promptly attend to client's needs to form as a form of reassurance to the client. Number 7, project patience and understanding when assisting the client in the routines. Number 8, provide privacy when assisting the client in his daily routines. And number 9, use words of encouragement to promote client to independently perform tasks and compliment the client for his efforts. So after 3 days of nursing interventions, the client eventually was able to actively and independently perform self-care routines. Last but not least is grieving related to negative effects secondary to terminal illness, metastatic colon cancer, as evidenced by the client and wife were in denial and crying upon receiving the HPE result. After 72 hours, the client would be able to recognize his grieving state and develop coping strategies to overcome his loss. First, establish therapeutic relationship with the client to carry out the sessions that will assist the client in overcoming his grief. Number 2, project empathy and authentic presence while interacting with the client. Number 3, use clear and simple statements when communicating with the client. Number 4, conduct grieving and reflective sessions according to client's capability. Number 5, facilitate the client in discovering his coping strategies so he may use them during difficult moments. Number 6, ensure some private moment for the client and his wife to convey their grievances. Number 7, apply intentional silence in a therapeutic relationship to reduce emotional liability by ensuring that he is being listened to. Encourage spiritual modalities depending on clients' cultural preferences, such as prayers and supplications. Number 9, document clients' progression through the grieving process to determine the effectiveness of interventions. So in the end, the client was able to, along with his wife, express his grief, found a purpose in life, and develop coping strategies to overcome his loss. So we come to the evaluation on the effectiveness of Jane Watson's caring model in clinical practice. First thing first, the nursing care plans presented in the case study previously contain elements of clinical Caritas process. So the examples of these elements are the use of the environment, empathy, basic needs, spirituality, comfort, expression of feelings, and the nurse's authentic presence, all of which can be traced back to clinical Caritas process. The caring model facilitates the nurse to view the client holistically and place the client as the center of care. So what I found that the strength of this caring model is evident in its usefulness in resolving clients' psychosocial needs, such as anxiety and grieving. But the main weakness which I've noticed is that this caring model has limited applications in answering questions pertaining to biophysical aspects of the client, such as decreased cardiac output. Another aspect which I like to point out that this caring model promotes individualized caring and healing. It is fully applicable in clinical settings with small nurse-to-patient ratio. However, if there is too many patients for the nurse to take care of, chances are the nurse may not be able to use the caring model to its fullest potential. Caring models value on the person's mind, body, spirit healing and lived experience may not be appreciated by nurses, systems, or organizations that do not share congruent values, but instead they only maintain the ontological stance of modern medicine or cure. So basically, they only care about the service provided to the patients, but ignore the caring and healing aspects of the patient. However, despite all that, clinical Caritas process can be utilized by healthcare professionals that practice the mind-body medicine, regardless if this practitioner is a medical doctor, a nurse practitioner, or even physiotherapist. This is especially useful in collaborative patient management, as caring consciousness within the healthcare professionals can result in holistic patient care and better patient outcomes. So I would like to conclude that Jane Watson's theory of human caring emphasizes on concepts of human-to-human relationships, caring, healing, and client as the center of care. These concepts are recognized within the nursing discipline, as nursing focuses on holistic care. So because of this concept, it will help to shape nursing's unique value, knowledge, and practice, as stated before. Complementation of both care and cure within the caring model humanizes nursing care, which promotes healing resulting in client's growth within the mind, body, and soul for the client's self-actualization. So I thank you for listening to my presentation and have a nice day. And these are my references.